treat-in cohort, more younger patients are getting. More, the duration of treatment or duration of addiction is decreasing. Earlier, the patients were coming with 40 years, 30 years, 35 years, even more than 40 years addiction. Now the patients are reporting with a lesser number of years of addiction. I mean, probably it is dawning into the environments or the society that they should get de-addicted or they should get treatment for this is what the message we are conveying. Thank you.
Thank you, sir, very much. We are already running at least, say, for example, 1 hour late of the scheduled our timings. Last but not the least, very important thing, Dr. Hardeep Singh, I'm taking one item out of the Pandora's box. We can ask many questions, many questions, thousands of questions like this. They are saying that addict patient or the psychiatry patient, a problem for himself, a problem for the family, for the Gali Mohalla, village, sector, society, nation, and to the Almighty.
When I say hard drugs, I'm referring to the illegal, illicit drugs. And when I said soft drugs, that means partly I'm referring to buprenorphine, which is a medicine used to treat addicts. It is a substitute for opiates, and we treat it as soft because it is legalized, it is not illicit. So that is what I mentioned, but that is what I wanted to convey.
Which is legalized, that is soft drug.
It is legalized to a large extent.
Okay.
Softer in the sense that it does not lead to any kind of the severe withdrawals like we see with heroin or with smack or with opium. But yes, the withdrawals are there that persist for a longer period than with the so-called harder drugs.
That's true, sir. Thank you very much, sir.
You're welcome.
They are saying that one more query on behalf of Dr. N.L. Gupta. You see, they are saying that hypertension and diabetes, we are taking the silent killers. But you see this substance abuse and drug addiction, it's a crying and devastating type of diseases. So we are to do something for that, and we can do, will do. Without doing that, we won't survive. You see, Dr. Deep Singh and Kanal Saab, Ish Kumar sir, will do and will fight out the problem. तुंदे बादे मुकाबिल से न घबरा है अकाब ये तो चलती है तुझे और ऊंचा उड़ाने के लिए. So we'll be starting another session of this panelist. And last question on behalf of Dr. Gupta sir.
I think I should ask this question from Dr. Hardeep Singh. Chandigarh is a city where most of the educated people are there, and it has been projected that most of the bottles are of alcohol are consumed there. So how is it that most of the facilities are there, concentrated there in that city, still we have more alcoholics there?
We still have lesser alcoholics as compared to other places. I'll tell you the reason. There was a gradual shift a couple of years back in Chandigarh where they opened large number of these liquor shops, and they were catering more to beer than they were offering the whiskeys and vodkas and the stuff. So that also was a policy which they had studied abroad and they had tried to implement in the Union Territory of Chandigarh, and they found that it worked. There were more than 250 such liquor shops in Chandigarh at one time, catering to only 48 sectors. So which actually averages out to almost 5 liquor shops per sector, which is actually a huge number when you look at the number of people they're catering to. And we found that they were selling more of beer. So it was like they were trying to bring down the severity to some extent. But to what extent or what level that will work out in the longer run is yet to be seen. What we see in addiction is once you start with it, I often compare it that addiction is more like a Lamborghini or a Ferrari without brakes. Once you start running it from Simla to Chandigarh, you cannot stop it. So the best is to put something, block it somewhere, and make it stop rather than letting it roll at a slower pace. So I don't really agree with the policy in the long run of shifting from whiskies or et cetera to beer. right, sir? But yet we see more number of patients turning up at my particular center with alcohol problems were coming from Himachal than from Punjab.
Thank you.
Thank you, sir. Thank you very much. So we are concluding.
Just hold on. There are few queries. There are few queries from the students or from the audience. Uh, it will just take about two,
Okay.
3 minutes. First question is, what is the average cost range for de-addiction? The average cost of de-addiction. You see, this cost will vary depending upon the duration of the treatment which we are offering. I am told by Dr. Ish that in PGI the average is about 5,000 per month, 5,000 per month. And from Dr. Hardeep Singh, I think
Well, compared to that, it is going to be phenomenal because we are a purely private organization. Uh, this roughly estimates to be around 90,000 a month, which includes all those paraphernalia which are not needed yet ordered by the families. If you talk purely of treatment, I would say it will not exceed 20,000.
Acha. In a rural de-addiction center which we are running in Chima, the average cost is about 13,000. This is what we are charging for about 4 weeks or 30 days. So the cost will depend upon the number of stay and whether the you see institution is private or a government run. Evidently, private concern will be more costly. Second question is which is more time consuming and challenging out of the de-addiction or rehabilitation. De-addiction is a only you see is the first step basically. First step. Most important and most challenging is the rehabilitation. Rehabilitation is very, very important and very time consuming. Definitely. Third question is major problem in rehabilitation is negative social image of the addict. How do we tackle them? Very important, very valid question the questioner wants to know the how to tackle the prejudices against addict and these patients. There's definitely it's definitely a big problem, and these patients are stigmatized by the society, as it has been brought out by our speakers also, that the public do not understand that this is a disease. They feel probably it's a deliberate phenomenon by the patient, and especially the association of criminal activities make their belief more rational that probably he's doing all these things. So what I feel personally is that you are right that stigma is attached to these patients, and this to take away stigma, it will be very long time consuming, and the best what we can do is to make the patients aware about this, that this is a disease and this needs treatment as many as any other medical illness. But the time mindset will take long time to change. But gradually, there's definitely the stigma has decreased with the mental illness. When we were studying, probably these illnesses were more stigmatized, and now the stigma is much less. So I think time will tell how much I mean stigma is gradually reduced. Definitely stigma is there, and that's a big handicap for the rehabilitation and the de-addiction of the treatment.
Thank you, Dr. Saab. Thank you very much. So we are concluding this and wrapping it up. Next session we'll be having panel discussion, and Colonel Rajinder Singh will be facilitating and he will be the moderator in the panel discussion. You see, during this panel discussion, we will be resolving a lot of queries. I think we all will be having some question in our mind. Please jot that down and come out with those. So we have the solution with this expert panelists. So the session will be including the panelist, Dr. Sukhvinder Singh. Dr. Sukhvinder Singh is Dr. Sukhvinder Singh is MBBS from Government Medical College Patiala. done his post-graduation in psychiatry from Albany Medical College, Albany, New York. He was a medical doctor in Indian Army too for 6 years in medical course. Rajinder Singh has also done private practice in Chandigarh for 6 years. He worked as a research assistant in schizophrenia research unit of Bronx Psychiatric Center, Bronx, New York. He's having work experience of more than 25 years and has worked on different designation and departments. He was medical director of inpatient treatment, Burns Accords Community Hospital, Port Jervis, New York for 3 years. So he has come a long way to join us here. Next panelist is our Dr. Rajinder Mohan. Dr. Rajinder Mohan is MBBS from Government Medical College Rohtak and MD in Psychiatry from PGI, Chandigarh. He is doing his practice in Dharampur, Solan and running a private hospital, 35-bedded nursing home there. Next is our Dr. Srinda Sethi, who is a renowned psychiatrist. He is coming all the way from Germany. Ma'am Srinda Sethi, most welcome, please. Our next panelist will be Dr. Onkar Singh, counseling psychologist, Chima Sahib, Punjab. And I welcome on behalf of Federal University, Akal School Public Health and Hospital Administration, Professor A.S. Padda and M. Padda. May I request Professor Padda to join our panel in the discussion. This has been with the approval of the authority. Kindly Padda sir. About Dr. Padda, if I'll start, say, explaining his CV, that will take a lot of time. Professor Padda, Professor and Head of Community Medicine Department, Public Health Department, Government Medical College, Amritsar, Patiala, Faridkot, so on and so forth. Director in PIMS Jalandhar. He is a great educationist in the public health, a dawn of public health in our state of Punjab and known authority in community medicine, social and preventive medicine in the country. And say, my Guruji, that concludes each and everything. Then Dr. Onkar Singh has, yeah. So, the panel discussion will be having the topics of human rights and ethics, drug trafficking throughout the world. We will be focusing throughout the world. Time limit 1 hour. So, Kanal Saab will be the facilitator. He will be moderating the session. Time limit would have to be taken into consideration because we are running behind the schedule. Then we'll be going ahead, valedictory and report of symposium, distribution certificates, so on and so forth. Lastly but not the least, with Dr. Kanal Saab, the vote of thanks will be there. So over to Kanal Saab.
Welcome the panelists. We have a very interesting topic of discussion which is confronted by us in treatment of drug addictions. Human rights, we know that human rights we should respect, and we should not violate any human rights, evidently, which are being violated right and left in our especially country, multi-cultured country. We will confine our discussion only to the drugs only. The rights of these addicts, let me spell out what are their rights. Their rights are, for example, if they do not want to be admitted, we cannot force them. This is the, it is there. Evidently, we cannot force any will, or the medical or the physician, they cannot force will when they refuse the treatment. This is, but we are confronted with a problem sometimes, rather many a times, the problem, these addicts, they do not agree for treatment. They are demotivated right from the beginning. What has happened? Why are they demotivated? Some of the factors we have discussed, because of the certain defense mechanisms which they are under having, or the perceptual disturbances which they have undergone because of the drugs, or because of the personality traits. So, for example, we will take a practical experience which we encounter. For example, let us say a patient has come to our center who has been brought by the relatives, friends, and the parents, see, in an intoxicated state. And we take the history reveals that the patient has been intoxicated by the parents, because the patient is not coming, not agreeing for treatment. They really genuinely want that he should get treatment, because the chaos he creates in the family, and the disturbance he is, you see, creating not only family but in the society also, they should cease. Anyhow, their desire is to get him treated. But they have made him to drink alcohol, and he is brought here in an intoxicated state, which is created by the parents or the relatives themselves. Now, this is an area where we have to, we, whether he is an intoxicated or because he is not willing for treatment. Now he cannot sign the documents. He is unable to sign document because he is unconscious or he is intoxicated. Now, what should we do at that time? Now, the second question is, second case is like this. You see, a patient has been brought by the relatives, tied down, with the limbs tied down to our center, and he is not willing to come, but he has been brought forcibly. Now, if we are giving him rights that he can violate, he cannot be admitted. If we think over his rights only, he cannot be admitted. But if we just think what is our wish is that he should genuinely be treated. But what should we do? If we admit him at that stage, we are going against the human rights. If we do not admit him, we are going against his health problems. And the patient has come from, he hired a family, the parents have hired a family, hired a taxi, and they brought from distant place to the center. How to deal with them? Achha, for theoretical discussion, I must say that, and I must respect the rights. But what I feel is that even the Hippocratic oath admits and says that you should do whatever is best for the patient, whatever is best for the patient. The autonomy of the patient is not taken into consideration even in the Hippocratic oath. So we can admit the patient as per the oath, but as per the human rights, we cannot admit the patient against his will. Secondly, if we go into what is happening in the countries, different countries, in Europe, this is a standing instruction that if an addict doesn't want to be admitted, you cannot force admission. Definitely, but we will get the views because our panelists, they are come from different countries. One is from German, the other is from America, and we will get their opinion. And they have got practical experience. Onkar Singh and Virinder Mohan, what do they do? For example, you see the problem in Western countries clear that you cannot admit the patient if he doesn't want to be admitted. But he's harming his body, he's harming his mind, the physique, the society, and he continues doing so. Now, if we see into other countries, for example, China. In China, a admission for the addict is compulsory. He has to be admitted. This is government orders. Number one. There's no choice. And if we see, this country was a country of opium eaters for some time. Some time back, known as a country of opium eaters. And now we know that it has advanced in almost all the fields, especially sports. Sports in any area. You have just finished the Asian Games. He is the topper. China is the topper in the Asian Games for ninth consecutive time. And now it has, I think, the tally of gold medal is more than 150, 60. We know it was a country of opium eaters. In Punjab, which was known for its valor, strength, and the service, and the youth of Punjab was well known throughout the world. Now, with this addiction, the problem has become so acute that these youths, they are not fit for even paramilitary forces. Whereas this Punjab youth represented army in the maximum percentage. Now they are not fit, not even fit for the paramilitary forces. These things we should have in our mind and then decide what should be done. Now I have posed two problems. A patient has been brought, another patient is toxic. I would like to have the opinion of the panelists and their views. What should we do under those ticklish problems? Thank you. I will request Sukhvinder Singh to please speak about what he would advise.
Well, the thing is, there's always a fight. There is always this kind of fight between autonomy of the patient and the beneficence, principle of beneficence. That means the good of the others. Uh, when the addict is drinking too much or consuming too many drugs, I think he has the principle of autonomy goes by the wayside because it is harming everybody. I think at that point, I think it's very much all right to intervene or what we call confrontation. I have read at places that if the patient does not want to come for the treatment, it is no use taking the patient to the treatment. But in my experience, it has been that the persistence pays. I think the near and dear ones and anybody who care for them, I mean, they should bring the patient to the rehab center and an attempt be made to persuade him. And it is something at which we have to be very persistent about it. I don't know at which confrontation, at which, whether it is 10th or whether it is 20th, I mean, sometimes the light bulb will go up. And it is, I think it is not the extraordinary uh, interviewing skills of the psychiatrist or the consultant which give the result. It is the persistence. It is the persistence on part of the near and dear ones and the physicians that they continue to persuade the patient and with a view to uh, punch holes in the denial that is very much the part of this illness. And so we have to continue to try. I think that's all that I'll say.
Uh, First of all, I would like to say that I am in this field for the last exactly 40 years in Dharampur. I'm very near from here. Uh, for the last about 10 to 15 years, the problem has really increased, and especially for the last 5 years, it is it is very disheartening to see that our young boys and girls are getting into substance abuse so much that it is disturbing. Now, I have a 35 bedded nursing home in Dharampur, and the number of substance abuse patients have increased alarmingly. I don't have a separate ward. What I do is that I consider them as just patients like others, not like uh, uh, just bevras or addicts or something. There are strict instructions to the staff that you be really sympathetic to them, because most of the time the police, the relatives, the neighbors, even the parents think that they have become criminals. By the time they reach to me, most of them are in psychotic stage. Nobody, no person with dependence will come to you by himself. This I have seen, not even one that he takes this. It's a very rare one. Maybe I have got two, three, four patients for the last 20 years that he has bhukti dependence or opium dependence or alcohol dependence and he wants to leave. No. He is always either persuaded or he is forced to be brought by relatives. So what I think is that it's an enormous challenge to the mental health professionals, not to the psychiatrists, but all the persons who are attached with the psychiatrists, including nurses. Your role is going to be very, very important. So I think I have got an open. I'm going to tell you my experience only. Open ward, I tell him, well, once he's out of that intoxication period, I tell him the gate is open, there is no guard. If you want to run away, go ahead. I don't mind. But if you want to be treated, let's stick. I will treat you, and I promise you that uh, that you are going to change your life. Then we do counseling, then we give therapy. The results are very good. Of course, they are not always good. Relapse rate is very high. So I think here you can't force all those patients who come by force. Uh, they they are in for definite relapse. Now you see, I'll also give my some some mind to these de-addiction centers, which are run by uh, licenses which are not authorized properly. Three of my patients have committed suicide after returning from those centers. They tell me their conditions is really horrible. That is the place where human rights violations are occurring and in a very horrendous manner. I think already lots of talk has been done. I think the number of uh, de-addiction centers under the guidance of a psychiatrist and with minimum of charges, if that is given to the society, I think lots of problems will be taken care of. Thank you.
Well, I am a German. I come from Germany. So my experience of de-addiction here in India is limited to about 8 or 9 months. The topic is human rights. So I'll just give a small view of the human rights, what we in Germany consider. Mainly and mostly in Western countries, human rights for addiction, we consider addiction as a disability, which means we want that all the addicted people should be provided with health care. And that we in Germany, our basic healthcare society takes care of addicts. The one main thing what we provide them is harm reduction rooms or drug treatment rooms where especially I don't know, Dr. Hardeep Singh said he is not in favor of shifting harm reduction, doing harm reduction, that means giving buprenorphine or methadone, which is probably not even available in India, to the heroin addicts, which is a very important issue. You see, because the heroin addicts are mainly the addicts who are long-term addicts. They are a boon to the society. They are transferring the infections like HIV, hepatitis, and even otherwise, it is a financial disaster. And our main aim in Germany is to help these people come to the normalcy of life, generally not avail- uh, uh, which is generally not possible. But at the same time, when they are being allowed to take methadone, that is a substitute for heroin. I don't know, is methadone available here? I'm not sure. But buprenorphine is available, which we provide the guidance of medical people, social workers, and counseling. And our results are, we out of 17 states, 15 states have up to 5 such centers in each state. As a result, we have reduced the criminality caused by these people up to 100%. The HIV infections are reduced up to 40%. And after they leave, we have seen that at least 10% of them, they automatically or freiwillig means voluntarily, they go for the treatment, which I do not see here. As I said in the beginning, my experience is not here so much, but they come voluntarily for treatment. So our main focus in Germany is on harm reduction, so that these young people, there are only three criteria. They should be above 18, they should be addicts for at least 2 or 3 years, and they should come voluntarily. That's the main thing. And secondly is that we also have a JESS program. That JESS means junkies, ex-users, and people who are using substitute therapy. So I cannot say much about the human rights here, because the experience I have, the stories I have been hearing here is that patients are being forced, they are being taken from home, which for me is a utopia. So I wouldn't be able to talk too much about human rights here in India. Oh, sorry.
I am Dr. Avtar Singh Padna. Presently, I am Director Principal SGL Medical College in Kapurthala district, which is coming up right on the GT road, 30 kilometers from Jalandhar and 50 kilometers from Amritsar. So I am probably the only person on the stage who is not from related directly to the psychiatric care of the patients. But I would like to make only 2 or 3 points. We are talking about human rights, about addicts. As far as human rights is concerned, I think everybody has very scant respect for human rights, even for a common man. The human rights are different for different sets of people depending upon their social status. But I would like to comment only on one thing, that the main gateway for drugs, we are talking about de-addiction or whatever it is, these are alcohol and tobacco. You hook on to alcohol, you hook on to tobacco, these are socially acceptable. The governments are concerned about revenue. And once you are on any type of alcohol or tobacco, it is very easy to enter into any drug. So initially they start with alcohol, because nobody is ready to talk about these drugs on a forum where we can take action, appropriate action. And for this, I think we need two things. One is political commitment, and second is administrative will, and then the professional support. With a small group of psychiatrists sitting here, and if we count the number of psychiatrists and we try to translate how many psychiatrists are available per 1,000 people, I think this is probably the most rarest commodity. So for that purpose, we need to have a team of, say, health professionals, and like they had said, we want their lapse rate is very high, so we need family support. We have to have the society, which includes friends, neighbors, and anybody who comes in contact. So unless we make a concerted effort, it's a teamwork. I think even if we detoxify them, or even if we go to de-addiction center, once they go back to their environment, they'll again come back after a few days. I have an experience, limited experience, about intravenous drug users. And the social status, they come from very good families, very poor families. And the average life of study area which we had that was about 2 to 5 years. Any person hooked on to IDU drugs, not being de-addicted or taken care of by anybody, the average span is not more than 5 years. And you see the consequences and the high rate of HIV in those groups. And then we talk about human rights. They are a danger to the society. We do not talk about the social cost, we only talk about the economic cost. I think there was a question that what is the cost of treatment for de-addiction, and it was 13,000 or 90,000, whatever it is. But if we see how many man days are lost, how many family members are coming, how many days are spent, how much money is spent on travel, how much production is lost, that is a colossal figure. So unless we have a paradigm shift of calculating the cost benefit analysis or the social cost of a thing, governments are talking about revenue, itne hazar crore aa gaya, ye ho gaya. So whatever money they collect for alcohol, the community or people end up spending about 3 times more than that on illness or on absenteeism or whatever it is. So unless there is a paradigm shift and there is a bogey of human rights, date entrant, that is the value system. When we were kids, if somebody used to complain to our parents that your son is doing things, you used to get a beating, a very good beating. But these days, if somebody complains again, the kids to the parents, ਉਹ ਕਹਿੰਦੇ ਇਹਨੂੰ ਤਾਂ ਆਦਤ ਪਈ ਹੈ, ਸਾਡਾ ਬੱਚਾ ਤਾਂ ਬਹੁਤ ਅੱਛਾ. So unless we accept that, and the value system is, there is some sort of paradigm shift towards the value system, the social media, availability of the drugs, that's also a factor. Only thing where we can, de-addiction comes after other factors. So it is, though it is important, but still we have to go for demand reduction. We have to control the supply. And cannabis, it's easily available in Himachal, as the figures say. So cannabis is more uh, common in these states. And the last point is, we talk about human rights. Most of the people now hooking on to drugs, they are from younger age. And if they do not attain the age of 18, I think the consent, we have the experts, they may be able to advise us on the matter. What will you do for them? So with these few words, I think that I made my point, and hopefully with having a pragmatic view, keeping in view the human rights, keeping in view the social havoc they play with themselves, with the family, and the fabric of the society, we have to take a view on that. Thank you very much.
We are already having a very interesting discussion since this morning. I am in the field of addiction treatments for the last 20 years at least. And I have seen many changes coming. And passionately, it is being debated. And for good, the things are changing a positive towards positivity because we are having now certain laws that who can open a de-addiction unit or who cannot. But still, I think it is very, very difficult, as all panelists have said one by one in their own views. My own perception about this phenomenon of drug addiction, or what is today's word is called substance use disorder, SUD, or variously it was called psychoactive substance use. I feel it is a very, very different type of illness. You can't just medicalize it. You can't just psychologize it. It has a vast reach. It is not affecting just the individual, as in all other illnesses. Of hypertension or heart ailment or diabetes is not going to affect his immediate family member. What to talk about his neighbor? In case of substance use disorder, the person not only is affecting adversely his own family, but also his neighborhood and largely society, and getting involved himself in legal wranglings and entering into many sociopathic or psychopathic affairs. It is, well, that family members bring to us the patient when they are totally feeling helpless, powerless, and they feel that he has created a havoc and hell to live with, and they want that he should be chucked away or taken away by somebody. Even I often get phone calls कि जी साडा मुंडा लै जाओ तुहाडे कोल बंदोबस्त की है, as Dr. Hardeep was already saying. When I say sorry, I don't have, ਉਹ ਕਹਿਣਗੇ ਤੁਸੀਂ ਕਾਹਦੇ ਡਾਕਟਰ ਹੋ ਜੀ, ਕਾਹਦਾ ਇਲਾਜ ਕਰਦੇ ਹੋ ਜੇ ਬੰਦਾ ਨਹੀਂ ਲੈ ਕੇ ਜਾ ਸਕਦੇ? Well, I will say I will sympathize with the family member. Family member might be having a different view or even a wrong view about his ward, that he or she is doing deliberately, that element of deliberation is there when he or she is using a substance. But when I say that family members feel powerless, helpless, they also become in one sense mentally ill also. So what I find is, in my overall perception of drug addiction, that it is also a family type of disorder. That is not just a disorder of the individual concerned, that he may be a core coefficient of that where the treatment is being focused. But at the same time, the family members become very sick. In my own practice, I have treated many spouses, particularly women, wives, sons, daughters, whose family member happened to be a drug addict. It has become a compulsory element in any type of addiction treatment to involve the family and talk about what is called family therapy. So where individual sessions are taken up with different family members, whether they're parents, or significant others, or children or wives. Particularly when I say children and wife, they are the biggest sufferers. I have seen in my cases sons committing suicides, spouse committing suicide, that they felt that they have failed. And there is another element which no speaker talked about today is, what I have found is, though if Colonel Rajinder Singh talked about projection, if he is able to correct me, though we have worked together, what is called as, now codependence is a type of family disorder where family members living in the same unit where an addict person is living feel helpless, not only helpless, powerless, but feel guilty that they are perhaps to be blamed for their wards or for their family members' addiction. Now, it is, when I talk about Dr. Rajinder Singh's projection content, he was talking defense mechanism of projection. Now, codependence is also a type of, if I can say, a defense mechanism, but different from projection. It may be called projective identification. Key projection is that you are blaming for your own ills to others, that others are responsible for it, that I am not responsible. But in the case of projective identification, it is altogether different, that you are internalizing all the wrong, all the things which the person is doing as yourself as responsible for those. That you start feeling guilty, that you are identifying yourself with all those negativities, that you are responsible for that. I have got many cases of that. Now, I have seen in my own practice, the patient does not want treatment, that he or she is not interested in any type of treatment. I will say, okay. And I have seen family members, wives, children, or father or a mother coming for psychotherapy or counseling to me. And ironically, it is the person who himself needs treatment brings them, who says that I am not interested. No, what we should do, whenever we are to frame any type of a law regarding consent of a patient, or whether it is an advised consent or it is a counseled consent, I think this very bigger idea of drug addiction as a disorder of many things has to be taken into care. Only then we will be able to address the thing in a perspective. And another point which I feel is addiction, well, society generally takes that it is the duty of only doctors, psychologists to treat the patient. I myself feel is that the subject of addiction, I will call it as addictionology, it's a huge subject. It is a conglomerate where so many things intersect. We are here having religion, we are here having sociology, we are here having anthropology. Because in Punjab, for example, we talked about Punjab, this opium addiction is having its own history, beginning with the Mughals. Then the Mughal generated Sardars, and the Britishers followed the same policy. And then this upsurge of this Sardars into this Jat culture. Because I myself have seen is Punjabi culture is predominantly a Sikh culture and predominantly Jat culture, where use of opium and liquor is taken for granted. It has its own cultural roots. And it is also playing upon one of the basic elements of Punjabi psyche, that is never to say die spirit. No, it is checking other way around. So how to check these all distortions? I think people from other disciplines must be involved. More research should be done. More research material is produced. For example, I often, along with Dr. Rajinder, say that we are yet to have a dictionary of vocabulary of drug addicts regarding the substances. There are so many. I have gathered so many words which I never knew earlier in chaste Punjabi language, and you can have a good lexicon out of that. It's a project in itself. So I would say that don't take things monodimensionally. So look at different dimensions. Even Alcoholic Anonymous is not having anonymous groups for alcoholics, but they are also having for children, for wives. Even at our Chima Center, we regularly hold counseling sessions for family members and group family sessions. These at present are organized twice a month or thrice a month. And another thing which I myself feel, and I will agree with Dr. Hardeep Singh also, he was talking about abstinence. I will involve that we ourselves are treating practitioners who are dealing with addiction. How much we ourselves are themselves involved in use of liquor, consumption of opioid or something else, or tobacco, use of tobacco, though it may sound paradoxical. ਜਾਨੀ ਇਹ ਨਹੀਂ ਮੰਨਣਾ ਚਾਹੀਦਾ ਵੀ ਇੱਕ ਆਰਥੋ ਸਰਜਨ ਜਿਹੜਾ ਹੈਗਾ ਤਾਂ ਹੀ ਆਰਥੋ ਸਰਜਨ ਬਣੂਗਾ ਜੇ ਆਪ ਲੱਤਾਂ ਤੜਾਵੇ ਪਲਸਤਰ ਲਵਾਵੇ ਤਾਂ ਹੀ ਉਹਨੂੰ ਆਰਥੋਪੈਡਿਕ ਸਮਝ ਆਊਗੀ ਐਡਿਕਸ਼ਨ ਐਕਸਪਰਟ ਹੋਣ ਦਾ ਮਤਲਬ ਕੀ ਇਹ ਹੈਗਾ ਕਿ ਦੂਜਾ ਐਡਿਕਸ਼ਨ ਕਰ ਰਿਹਾ ਉਹਦੀ ਟ੍ਰੀਟ ਕਰ ਰਹੇ ਹਾਂ ਪਰ ਅਸੀਂ ਆਪ ਜੋ ਕਰ ਰਹੇ ਹਾਂ what type of behavior we are having. After all, whenever a patient comes to us, he or she sees a big image in us. And at Chima, what we do is we select only those staff members who are at least drug free. And this is what we try to ensure. Staff from our class 4, security guards, medical professionals, psychologists, the first condition is not what the qualification they are having, whether they use liquor, tobacco. अगर मेरा होते सिक्योरिटी गार्ड टबैको खांदा तो टबैको अंदर भी ले आऊगा. So it reflects upon not only I myself but others also, the character traits also, the character strengths also. So many people are here talking about value-based education. Perhaps nobody has talked about one thing. Now, I think ਸਾਡੇ country ਜੇ ਪਹਿਲਾ ਹੁੰਦਾ ਤਾਂ ਚੰਗਾ ਹੁੰਦਾ. Now it was done by APA, American Psychological Association. For example, the American Psychiatric Association is having its own manual of mental illnesses. This is called Diagnostic and Statistical Manual, DSM. Its 5th version is now in circulation. The American Psychological Association tried to have its own manual because for the last 20 years we are observing another movement in psychology which is called positive psychology. They say that we had been talking about illness, sickness. Let us talk about something which makes a person a better person, a person more happier person. So they evolved a manual. It is called CSV. It has been published by Oxford University. Now its second edition has also come because first edition came 10 years back. The name is Character, Strengths and Virtues. Now it is collecting all the traditional civilizational wisdom that what type of practice strengths in a person should be there so that he becomes more self-efficacious, becomes more better person to assess or take his decisions in a right manner, assessing all types of risks. So much is happening and my only submission is let us not be monodimensional. It is not the only responsibility of doctors and psychologists to look into addiction, but others must come up, spiritualists, religionists, anthropologists, sociologists, literature people. It would be better if we are having that type of symposium. Now we are having a panel which is very monotonous and I object to it. Thank you.
Thank you very much. We had very valuable opinion of the panelists. Uh, you have heard about patients being psychotic. Dr. Virinder Kumar commented, and he said that when the patient comes, he is evidently he lacks insight. Whether he doesn't know whether he is suffering from any problem or not. And what is felt is that each case needs to be tackled on its own merit. For example, patient is refusing treatment and we feel that he needs treatment. And how to go about it? We have to have counseling sessions. We have to persuade him through certain people with whom he has better rapport. For example, a peer counselor, and an individual who had undergone this experience of de-addiction and has become symptom-free. Probably he may be more amenable to his suggestions than to the suggestions of a physician or a psychologist. So all these things we have to take into consideration. We cannot solely depend or say that we must respect always his rights. We have to certainly sometime take decisions when he may not agree, but gradually with counseling and probably he becomes ambivalent, and then when he gets admitted, he even after a few days or 10 days he admits that it was his fault, he didn't agree, and now whatever has been compelled or given by compulsion by the relatives they have brought him, it is good for him. So what I feel is that one has to decide each case on individual merit. We cannot always go that we must respect his rights. Yes, we always should. But sometimes a patient who is ill, whose perceptual functions have been totally distorted, who is not knowing whether he's damaging himself or not. So sometimes we have to have an approach which is I mean amenable to both the physician and to the patient, and we should do it by I mean coaxing, persuading, counseling, and other methods which we can do. Regarding harm reduction, uh, Dr. Hardeep Singh made a comment that he is not in favor of substitution therapy. I think is a comment which needs more clarification and discussion. But what is felt is that pure substitution is considered by laymen or lay public, I mean, secret business, and going to certain people about having drugs or having material which is not pure, but for example, taking cookie or crushed opiates. So definitely it is but in certain countries, even substitution therapy is prohibited. For example, in Russia, there's no substitution therapy. They do not believe it. It is forbidden by government that they should not be given any substitution therapy. So, I mean, we have to decide about our consistent with our own cultural patterns, what is to be done. I would like the comments of rights and addiction from Dr. Hardeep Singh. We have got experienced psychiatrists, and Dr. Ish, they can come here, please, and give their comments and words of wisdom. They have got a lot of experience.
Thank you so much, sir. I'll just take a few minutes to clarify on whether we should give opiate substitution treatments or not. Um, Going with the practicality of today, this is not US, this is India. In the US, everything is regulated. Whether you can practice right medicine is regulated. Whether you're practicing as a nurse, that's a regulated profession. How much medicine you can dispense is regulated. You cannot just walk into a doctor's chamber and claim, kindly give me so many pills. What is happening in India is there is no regulation. A patient comes to me, he can take, say, 100 pills of buprenorphine, which is the commonest opiate substitution treatment we have available in the country at the moment, and then walk to another one, pick up 100 tablets from there, walk to the third one, pick up another 100 there. This is actually what is happening. They are hoarding those tablets, they are building, a stockpile of those at home, and believe me, they are even selling those at a premium. Those very tablets, they find their way into jails, into even rehabs, and they're being abused by addicts when they find that the primary drug of choice is not available. So that's why I said I am not in favor of OST because I don't stay in the US. I am in India. Here we tried Aadhaar card for so many policies. When that Aadhaar will be successful and we can link all the doctors, dispensaries, pharmacies to that Aadhaar card, believe me, that will be the time when we can say yes, go ahead with OST. Till then, we'll have to hold it back. Thank you.
Thank you. Thank you very much. Again, just a point about this harm reduction. I'm again reminded of harm reduction. I mean, providing sterile syringes to the intravenous drug users is again banned in Russia. They don't. They interpret that providing sterile syringes to the users is encouraging them for more dependence on the drugs. Thank you, Bachcha. Next.
Rajinder Singh,
I think
ਇਹਦਾ ਮੈਨੂੰ ਪਤਾ ਹੈ ਨਸ਼ਾ ਕਰਦਾ ਜੇ ਇਹਨੂੰ ਰਾਤ ਅਸੀਂ ਰੱਖ ਲਿਆ ਤੇ ਇਹਨੂੰ ਵਿਡਰਾਲ ਸ਼ੁਰੂ ਹੋ ਗਈ ਤੇ ਕੌਣ ਜ਼ਿੰਮੇਵਾਰ ਆ? So he is out after a day or so, then he again comes and does the same thing. So in the criminal justice system which we have and the police system of uh, uh, police in the states, I think we need to see human rights versus welfare of the public. Second point is the relationship between the contractor and the laborer. Those of you have seen how the construction laborers work. ਉਹਨਾਂ ਨੂੰ ਓਪੀਐਮ ਵੀ ਮਿਲਦੀ ਆ, ਉਹਨਾਂ ਨੂੰ ਸ਼ਾਮ ਨੂੰ ਸ਼ਰਾਬ ਵੀ ਮਿਲਦੀ ਆ ਕਿ ਅੱਜ ਕੰਮ ਕਰੋ ਤੁਹਾਨੂੰ ਮਿਲੇਗੀ, ਉਹਨਾਂ ਨੂੰ ਪ੍ਰੋਕਸੀਵੋਨ ਦੇ ਕੈਪਸੂਲਸ ਵੀ ਮਿਲਦੇ ਨੇ, ਉਹ ਬਰੂਫਨ ਵੀ ਖਾਂਦੇ ਨੇ, and they actually become hooked up. So whether it's a human rights violation because it is in the economic interest of the worker, contractor and everybody. So we need to look these things also where the economic interest override other interests. So, so I think we need to discuss these points also so that the total criminal justice system is again either it can be modified or there should be some guidelines that if the addicted court, the jail people are not ready to take him. ਕਿ ਕੀ ਕਰਾਂਗੇ ਜੀ ਇਹ ਤਾਂ ਜੇ ਸ਼ਾਮ ਨੂੰ ਗੜਬੜ ਹੋ ਗਈ ਤਾਂ ਕੌਣ ਜ਼ਿੰਮੇਵਾਰ ਹੈ? The police is not ready to keep him in the police station. The parents are not ready to keep him at home. So again, he either becomes a bigger criminal or whatever it is. Thank you.
Thank you, sir. Now I would request Dr. Rajinder Singh to please come up on the stage and present token of appreciation in shape of mementos to the Honorable Chief Guest, Major General M.S. Kandal.
Thank you very much. I convey my thanks to all the panelists. This panel now discussion comes to close. We have other issues now. Thank you very much again.
Now I would like to request Rajinder sir to please come on the stage and present the token of appreciation in shape of mementos to the chief guest, to the Honorable Chief Guest M.S. Kandal.
I must confess that I have learned a lot about substance abuse, and it has been very educative and very enlightening and very interesting. Hopefully, all these thoughts which have been discussed are going to be disseminated through print and electronic media to lot many people so that more people get informed and become motivated to undertake this crusade against this menace. Thank you.
I request Air Vice Marshal Manjeet Singh ji to please come on the dais. Dr. Padda, please. Dr. N.L. Gupta. Dr. Chauhan. Dr. Chauhan. Dr. Ish. Dr. Dr. Hardeep Singh. Dr. Sukhvinder Singh. Dr. Vrinder Mohan. Dr. Sarinder. Ankar Singh ji. अच्छा, ओंकार सिंह। Thank you. Thank you very much. Now, it's a very pleasant duty for me to thank all the people who have organized and made this symposium very successful. Firstly, I must thank the chief guest, General Kandal, who has a very busy schedule in Chandigarh, involved in so many medico-social activities and coordinating the government institution, the medical institution and the private institution and delivering the maximum good to the rural underprivileged people. I am grateful to Air Vice Marshal Manjeet Singh, who is a thinker, a philosopher, and an author that he has come here, friends, the blueprint of which was drawn by Dr. Devinder Singh and Dr. Neelam Kaur, and they inspired all these organizers to put in their best and to bring in the results which you have seen here. I must thank them also. They are the inspirers. My My thanks are due to the organizing secretary and the president, uh, Sujana Chakravarti and Sudhakar. Thank you very much. Uh, all this has been possible due to the showering of blessings of Honorable Babaji, who, though physically is not here, but everything which is happening here, he is in the know of it, and it is he who has. I must pay my gratitude to all these delegates who have come from different states and the students in particular who have, I must say, they must have gained much more than what they were. They are wiser now what they were when they came here. Thank you, one and all. Thank you.
Thank you so much, sir, for sharing your profound knowledge with us. Now, I would like to request everyone sitting in the hall to break for Septimus lunch and assemble sharply by 2:30 p.m. in the hall back. And there will be concurrent session by 2:30 p.m. in auditorium on the other side. Thank you, everyone. You can go for lunch now.